Hello, my name is Dr. Justin Brandler. I'm a gastroenterology fellow at the University of Michigan. Thanks so much to the IFFGD for inviting me to speak to you all today about IBS. I'm really hoping that today provides you a lot of really practical tools to live your best IBS life. I know this condition can be really incapacitating for some patients, and really trying to provide you some hope as we work through this process together. So providing some practical tools here you to beat the battle with your bowels. So first we'll start with what IBS is. So many of you already know, as you're watching this, it stands for Irritable Bowel Syndrome. Pretty central to the diagnosis is some component of abdominal pain or discomfort that's associated with abnormal bowel movements. Usually these are related to constipation or diarrhea, but actually there are some criteria that are for neither constipation or diarrhea, or both, as we often see, and that condition is often called IBS mixed. It's got very complex physiology that we're continuing to discover more and more about as the years and the research evolves. I think it's also really helpful to talk about what IBS is not. So inflammatory bowel disease, or IBD, is something that we always kind of have in the back of our minds that we want to make sure that we're not missing. But that is specifically Crohn's disease, ulcerative colitis, microscopic colitis. Also, it's important to recognize and to state that IBS is not fatal, okay? It doesn't affect the quantity of your life, but this by no means diminishes the impact that it can have on your quality of life. Finally, IBS is not all in your head, okay? I'm sure, unfortunately, many of you maybe have been told by other providers, maybe even other gastroenterologists, that, what you're experiencing is all in your head, and, we do these tests and they're negative. And I really want to encourage you and provide you hope that both myself as well as so many other providers that I work with don't believe that this is all in your head, that you're truly experiencing these symptoms. However, I also think it's so important to recognize that the brain does contribute actually a lot to the problems that we see in IBS, and we'll dive into this more later. And we're actually starting to brand functional GI disease, is what IBS falls under, into more of these disorders of brain-gut interaction or brain-gut microbiome interaction. As we go forward, it's more descriptive of what the condition entails. So now we're going to dive into hopefully a really practical approach that will empower you in your next visit with your provider to get you both on the same page and meeting your goals together. So before that visit, you really want to organize your thoughts and your experiences surrounding your IBS. So I know notebooks can be really helpful for self-reflection, for discovering triggers. I have some patients who have very detailed binders that have tabs of different things. The problem with that is that notebooks often aren't really that helpful during limited office visits. And I always feel bad if I have to say, well, I appreciate that you're so thoughtful about your care. That's wonderful. But if we go through each of these different fine points, it's going to detract from the time and the quality time I really want to spend with you as my patient. So we're going to go through actually an example of a one-page summary that could be very helpful for us as your providers, which I'm just calling an IBS snapshot. So a lot of people wonder, what tests are you looking for? A lot of you have had a number of different tests over the years even, and especially when you're coming to a referral center like the University of Michigan. So we're going to go through some brief tests. And along the way, feel free to take screenshots. These PowerPoints will be available to you later for your review, or just take a quick picture with your phone if you want to have that. That's perfectly fine. So first is, some lab work, basic lab work that we're going to want to see: your blood counts, liver tests, inflammatory markers, that C-reactive protein. Celiac testing is also really pertinent for especially diarrhea. Then stool studies. So if you've had fecal calprotectin, a sign of inflammation, or lactoferrin. And then a lot of times, depending upon the situation, we're going to want to check for some infections potentially as well, Giardia and C. diff that have been hopefully ruled out. Imaging. So a lot of people wonder, what exactly do you want? So Imaging the full reports are definitely helpful. We're usually looking for CT scans or MRIs of the belly in this case. If you can have those images placed on a CD and actually sent directly to us, or sometimes this can all be done electronically, if it gets pushed directly to our providers, our radiologists can actually overread it. And I'm sure many other institutions have a similar type of structure. That's very helpful. And then finally, scopes. So upper endoscopy, colonoscopy, full reports are really the most helpful, as well as their accompanying biopsy reports if you've had biopsies done. In this case, actually, images are less important for us. They're usually kind of grainy and black and white. But this is kind of giving you a collection of probably the most helpful things that we would like to see coming into that visit if we don't already have access to it through our electronic medical records. Now, we're going to go through step by step here of what I would find is a really helpful summary for a patient to come in with me so we can spend a lot more time in kind of that quality personalization aspect of the visit for your care. So first, if you really try to think about your predominant symptoms that you're experiencing. So for example, I have diarrhea, and if my abdominal pain is better after having a bowel movement, it happens on average 3 to 4 days a week. I know IBS is a very complex condition, and you have good days, good months, bad months. And so it's not necessarily going to be this is how it is all the time. But if you can kind of get a sense of what's my predominant pattern, that helps us target your treatments accordingly. Triggers. So this is, for example, garlic and onions are a very common trigger, or eating out, stress, just food in general. But if you can really find the specific types of foods, that can be helpful, but we'll talk about a more personalized way of doing that later. Prior testing. So kind of this just here just outlines for you brief summary points of and the abbreviations of those different lab tests. You can have the results attached, but if you kind of have a summary of I had this blood work, these stool tests, those types of things can really just help us quickly peruse what you've had done, what maybe the holes in the workup you've already had done that we can fill out, as well as the dates, because if it's decades old, then maybe we need to repeat some things. Previous treatments. Now, this is actually probably one of the most helpful things you can do for us because, you know, many of you have been on a number of different medications. This is a journey. And so if you're able to look back at what was I on? Because if it's something like a green pill, it's very hard for us to know what exactly you were on, and we don't want to repeat the same thing, but we also don't want to you know, ignore potential options that we would have. So this is kind of giving you an example of a table here where I outlined the you know, treatment I was on before, so a gluten-free diet. I was on it for 4 weeks, it just wasn't effective. That's a pretty adequate trial. This also, though, this hyoscyamin, so this is a very common medication that we use for cramping, but here this patient, you know, only had tried 1 dose. They felt jittery and, you know, basically it didn't work. Well, sometimes we really encourage you and coach you in terms of medications that we think might be good for you. And if we have a sense of like, well, it wasn't really giving it the good college try, if we could have that, we'll really open up more doors. As we want more open doors than we want closed. And then here's another example of like an antibiotic or something. And if you got C. diff, okay, then we're probably not going to be going for Augmentin for you. C. diff is a type of infection. Finally, it's helpful going forward to have a goal. So what's your main goal with your treatment in our visit today? You know, I want to leave home without worrying about diarrhea. Very reasonable goal, and something to help me help you to reach that goal. Some other things is like, you know, concerns I have. Will this be my life forever? You know, that's a very common concern and question. Treatments that you're interested in, we really want to hit those well and make sure that we've talked about them. And then also treatments that you're not specifically interested in can also be helpful points of conversation. For example, like antidepressants, we use those a ton in GI and especially in IBS. And unfortunately, there's still quite a bit of stigma surrounding mental health, and some patients, you know, I have had some specifically say, I don't want to be started on that because I don't want depression in my chart. It could affect my insurance, my job, other types of things. And those are really helpful conversations to have up front so that we can work together to still reach your goals, but also respect the certain concerns that you have. So one actually helpful resource is the ACG's, the American College of Gastroenterology's IBS treatment checklist. So you can actually go online to that URL at the bottom there, and it'll maybe jog your memory as to previous treatments you were on. You can make those little check boxes and then print it off to bring it, and that can be another option for you. Now we're going to dive into more treatments in terms of natural supplements and pre and probiotics, and we'll start with IBS diarrhea. So soluble fiber, so one that dissolves in water, you can see some examples here, Metamucil, Benefiber. The powder actually in general works better than the capsules or gummies. You need a lot of capsules to get to the recommended dose of 30 grams a day. There's some, other effects like making you feel less hungry, things for your blood sugar that actually are beneficial here as well. If you're having some bloating, Benefiber or Citrucil may be better than something like a Metamucil. Prebiotics, actually, you could just replace some of these fiber with the name prebiotics, and some of them actually have, because in general, it's high fiber foods that are feeding the gut bacteria to maintain a healthy balance. It actually hasn't been studied as well as, soluble fiber in that setting. And so likely not better than placebo if it's in a pill form and not specifically these fiber supplements. And then probiotics. So a ton of, attention for this in the media and things like that. Unfortunately, there are a lot of various strains and preparations, so it makes the studies hard to interpret the results. It's not currently specifically recommended for IBS, but the most studied strains in IBS are Lactobacillus and Bifidobacteria. So if you see those definitely in the probiotic strain, that's a higher likelihood that you might be getting some benefit. I have here listed some brand names that if we are going to say probiotics to patients, the ones we maybe trust a little bit more. Next, we'll talk about some herbal treatments. So for IBS diarrhea, so iberogast actually has been decently studied. It's got caraway oil in it and some other things. It's actually helpful for IBS as well as functional dyspepsia, so more upper GI discomfort. Caution for you if you have liver disease or some bleeding issues, but otherwise a generally safe medication. Peppermint oil also has been actually quite well studied in some randomized trials in this, has been shown to reduce symptoms from IBS and functional dyspepsia. IBgard is a popular brand, but there's also generics that are less expensive available. Some less studied options, but they have had some studies for them and show some promise is turmeric or curcumin, felt to possibly have anti-inflammatory effects. Possible role in constipation as well, but not as robust data as we have for the iberogast and the peppermint oil. Same thing for glutamine and berberine. So glutamine's been looked at this leaky gut, which, there's a lot of research surrounding this, although we don't have a validated tool yet necessarily to use in clinical practice to confirm increased permeability is how we refer to it. And berberine is another one that potentially has some benefit in decreasing diarrhea frequency and is relatively safe, but again, not as well studied. How about for patients with IBS constipation? So fiber here plays a key role as well. You want to aim for more water than you do with the diarrhea, where you want to kind of aim for less water because it can kind of affect you on either side of things. Aloe vera actually is another type of natural remedy that has anti-inflammatory and pain relief effects. Just be cautious as it can affect some absorption of some drugs, including blood thinners. And then pre-probiotics, those are kind of the same things as we discussed earlier. As far as IBS-C, Bifidobacterium animalis is the one that's most studied. But again, further studies in the future will hopefully limit the specific types of strains and get us better benefit, but currently not as recommended for IBS, but not necessarily problematic. It's more problematic for your pocketbook often than anything else. Okay, now we'll move to diet. So for IBS diarrhea, many of you have probably heard of a low Fodmap diet. That's probably the most well-studied diet in IBS diarrhea. It's important to stress that it's not a forever diet, okay? Because this can be a very restrictive diet that we don't want you to stay on forever because it can restrict some important nutrients. You use that restriction phase to kind of figure out, am I a responder to this diet or not? And then ideally with the guidance of a dietitian, you go through reintroduction of foods, discovering your triggers, and then personalizing your plan for you. Gluten-free diet is another common diet that I'm asked about, and this is if celiac disease has been ruled out. because we know it's definitely important for celiac disease. But as far as IBS, we actually currently don't recommend it because it actually can decrease a lot of the whole grains that are important for your overall health. However, there's more and more body of literature showing that there can be this non-celiac gluten sensitivity, that patients seem to be sensitive to things. But to complicate things even further, it's felt that potentially it's not even necessarily gluten. It may be other things within wheat causing symptoms for patients, like fructan, or some patients may be having a wheat allergy to other components in how we process wheat now that we didn't used to, decades ago. That's more the problem than actually the gluten itself. So I provide this little kind of diagram to hopefully outline as far as restrictiveness of diet going from, the most open diet, whole grains, which are important, to the most restrictive diet, which is more the low FODMAP, the restriction phase. And that there are some other options in between there, such as a wheat-free or a fructan-free diet that I encourage you to discuss with your dietitian as well as your provider as potential options for you. As far as constipation, so some natural laxatives here are more the high FODMAP foods like prunes, peaches, rhubarb. A low FODMAP diet, which is actually finding some more promise in terms of constipation treatment, is actually kiwis can be helpful for this. Now I want to dive into something that I think is really important, but maybe not as well recognized, so GI behavioral health. Okay, so this is possibly our most effective non-medication option for IBS treatment. Now, in our last few minutes together, the medication, so what we often more talk about, but I want you to really discuss this more with your providers because I think that's a really important conversation and things that maybe you've already been on before, but we're going to summarize these here. So for IBS diarrhea, we use mechanisms like hitting the brakes of stopping things in the colon. So that's things of like loperamide or Imodium, Lamodal, that's diphenoxylate. Bile acid binders, a lot of patients I find haven't actually been on these and they potentially can be very beneficial as bile acid malabsorption can be a common cause of IBS diarrhea, and some other less common prescription medications there. Cramping calmers, so these are actually more as-needed therapies. They're anti-spasm medications, so hyoscyamin and dicyclamine. Decreased bacterial buildup. So you hear a lot about small intestinal bacterial overgrowth. So this is where we'll use something like rifaximin. It has several randomized controlled trials behind that, as well as various other antibiotics that we may use. Sensitive nerve settlers, okay? So this is where we harness the power of this gut-brain connection and use low-dose antidepressants such as tricyclics or SSRIs or SNRIs to use to calm down, and this is often more on the pain aspect of things. And then finally, command center control, using those GI behavioral health techniques to help us through the guidance of a GI behavioral health specialist. Then for our IBS-C patients, so low-cost laxatives here could be Miralax, mag citrate, milk of magnesium. Those can be very beneficial and cheap. Step on the gas. So this is some of our stimulant laxatives, so like Senna and Bisacodyl. Caution here, sometimes patients get some cramping, but again, trying to not go in it with a nocebo effect if I'm going to get cramping, but just recognize that that can be a potential side effect of these. Now we're moving into more prescription options. So linaclotide, that's Linzess. You see a lot of commercials about these help to secrete fluid within the colon to help move things along. Amitiza and some other ones. Amitiza is lubiprostone. Propulsin. So this is a newer kid on the block, the prucalopride. It's actually been around for a long time, but recently FDA approved. Tegaserot actually was previously on the market for IBS-C, but then actually taken off for cardiac reasons and things, but now actually brought back on the market. So important to talk to your doctor about if you would fit in that category of patients that can be on it safely. Now, this is something I really want to bring up is that, for some patients, it's actually not the colon itself, but more the muscles at the bottom of the pelvic floor that are not relaxing well enough. And that's called pelvic floor dysfunction, or there could be other combinations of problems that limit your ability to expel the stool. Okay, so I call these brick wall breakers. So squatty potty, which actually hasn't been evaluated in a randomized trial, but relatively cheap option to try, as well as pelvic floor physical therapy, and talk with your doctor about tests and things like that that could help, assess if this is potentially your problem. Sensitive nerve settlers, so some of the side effects of the other antidepressants can actually cause constipation, so we avoid those, but SSRIs actually, we kind of harness some of the side effects of diarrhea of some of them to use for patients with IBS-C. And then finally, again, that GI behavioral health component. So now wrapping all of these things together to really provide you power and feel just that there's hope for you in terms of living your best IBS life. We've covered a lot of ground today. So recognizing IBS as a problem along the gut-brain microbiome axis, preparing that IBS snapshot before your visit can be a really powerful tool to make the most out of our limited time together. And the numerous effective treatments actually that we talked about. So working with your provider to kind of tip those scales to really maximize the placebo effect that you could get from it, in addition to obviously the therapeutic effect, as well as trying to decrease the nocebo that you potentially may be going into it with. Many natural supplements, herbals, diet options that are, I think, worth trying or at least exploring. GI behavioral health, like cognitive behavioral therapy and gut hypnotherapy, is actually very safe and very effective for a lot of patients. And then many prescription meds, as we just talked about, that can target a lot of variety of mechanisms. So thank you so much for listening. Again, thank you so much to the IFFGD for inviting me to talk. I'm active on Twitter, and I'm just so excited to work more with you as my patients, or just see you out in the community and have further discussions together. But thanks again so much for listening, and I hope you have a great rest of your session here.